Good afternoon, and welcome to HealthSystemCIO.com's All-Star Panel, Communications and Care Coordination, What's Missing? A complimentary webinar from HealthSystemCIO.com sponsored by DataMotion. Just a little bit of housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I will be your moderator today. We're going to encourage you to ask questions. It's a good topic for it. You can type them in whenever they occur to you in the Q&A box in the lower right-hand corner of your screen. We'll leave the default set to all panelists and go ahead and send them in. We'll be posing them later in the program. You can download the deck by using the URL on your screen, and we've also got a shortened URL at the bottom of all slides. And we are recording today's event. We'll get that posted to our YouTube channel just as soon as possible. And you'll receive an email when it's ready, so you can go ahead and check it out. Just so you see how we're going to spend our time today, we'll look to go about 45 minutes in total. First, we're going to have our panel discussion featuring Dr. Bill Braithwaite, founder of Braithwaite Consulting, Dr. Peter Tippett, CEO of Health Accelerate and Chairman of DataMotion Health, and Dennis Robbins, Chief Clinical and Business Intelligence Officer with KPN. I will be showing slides as our speakers are talking that has some of their biographical information up there, so you can get more information about them. But we're going to jump right into our conversation with our speakers with a sort of a table setting question and get to know about a little bit about each individual's organization and where they're coming from. So, Dr. Tippett, would you start us off?
Sure. Yeah, this is Peter Tippett, and I've been a doctor, since I could be, I guess. And but I was into computer sciences even before the PC came along, and early on got the bug on trying to mix the two things together. About 12 years ago, I got involved with what was called the PTAC, the President's Information Technology Advisory Committee, which is where the first health czar got named, Dave Brailer. And I met Bill Braithwaite there. Bill Braithwaite is the guy, you'll hear him in a second, who people call him the father of HIPAA. Bill and I sort of hit it off because the problem that HIPAA was trying to solve really boiled down to the same problem that we've been trying to solve for the last 20 years, which is how to get computers to actually do something useful in the furtherance of healthcare or care coordination or anything in the AAA. So I've been passionate about that. I've joined Verizon as its chief medical officer about 8 years ago. I had a computer security company before that, and I did the first antivirus product before that. But really just a tech guy who's interested in how to make computer security and healthcare work and drive this stuff forward.
Excellent, excellent. Dennis, you want to jump in?
Sure. I don't come out of the IT world primarily, but have gravitated towards it. My training has been in ethics and health policy. And early in the game, I realized that the only way in which we were going to make really significant changes in terms of our system or our non-system, our health care system, was to have information available that will give people something that can be actionable. And I believe that the solution was going to be through health information technology, so infuse myself into that domain. And what I'm bringing to the table today is I believe that if we're going to engage people and get them involved and change their lives and have them be interested in getting and becoming healthier, we need to change the complexion of how we do things. We need to focus away from a sickness model and a patient model to the person, because patients are subservient, they're passive, they're wounded, and people, if it matters to them, it's important enough to them, if it's something that will be something that will change their lives, and they see the value in doing that, then indeed they'll make that change. So I'm interested in infusing the lessons we can learn from information technology and a smarter way of approaching it, along with getting the person engaged. And the person can be the physician, the person that we call the patient. I don't like to use the word patient, but really make a difference in that domain.
Excellent. Dr. Braithwaite?
Yeah, this is Bill Braithwaite. After teaching at the University of Colorado School of Medicine for a couple of decades, teaching new physicians how to practice medicine better with computers by their sides and getting feedback from them that things weren't happening fast enough. I took a sabbatical and came to Washington in 1994 and ended up in a health policy fellowship that enabled me to write a law called Administrative Simplification. And when that law got attached to and passed as part of HIPAA in 1996, I got hired by the Secretary of HHS to lead the writing of the regulations to implement it. So that's where the Dr. HIPAA moniker comes from. And after doing that for 7 years, I went into private consulting, and I'm still doing that. So here we are.
So if you have rotten tomatoes handy, you can throw them at Bill now about inventing HIPAA.
Yeah, it used to be, I used to get a lot of arrows in the back about that, but now it's mostly they're handing me fruit in my hand instead of throwing it at me because they're realizing how important the HIPAA rules have turned out to be for the progress of healthcare in this cybernetic world.
Yeah, Dr. Braithwaite, I mean, HIPAA is intended to help people share information, and sometimes it's been used to sort of inhibit that. So what are your thoughts around that?
Oh, well, yeah, it's partly people were afraid of it. You can't imagine how many times people were telling me that they were being told by their lawyers and their administrations that they couldn't share data with the patients because HIPAA said they couldn't, when in fact it says exactly the opposite. And people were afraid they were going to be thrown in jail for talking to their patients about things, just crazy misinterpretations of the law. So anyway, we are gradually getting to the point where it is being more well understood. The penalties for violating the HIPAA rules are being more broadly broadcast so that people understand what's required and what isn't required. So it's getting better, but we still have this problem that the view for patient-centered care and care continuity across the various venues in which we all receive health care over our lives is failing to come together properly as envisioned by the original HIPAA rules.
This is Peter Tippett. When HIPAA came out, I like to look at it as the P in HIPAA is for portability, which is interoperability, which is data exchange. And, you know, the problem that was generally trying to be solved was getting people to share information in a digital way and make it positive for moving the ball forward. I'm a child of this whole, as most of us are, of this whole revolution, the internet revolution or the PC revolution or the mobile revolution. And nobody had to twist anybody's arm to make them use word processors or email, right? Everybody just found that natural and useful and positive and productive. And, you know, we look back at the productivity of our economy, and a lot of the improved productivity can be measured and attributed to the IT revolution that happened. But, you know, when HIPAA came out, I would like to, think that HIPAA was largely a response to the worries that doctors and other people in the health world had about privacy and security. A lot of people naturally didn't use email to talk with each other about their patients, and part of that was because people were worried about privacy and security. And so the idea was if you could make a wrapper on it that could help people understand a few simple things to do to get that part taken care of and then get on with sharing information, that would work. But Bill and I came together 13 years ago under a charge of the White House but basically the charge said, if I'm summarizing several years of testimony and work and whatnot, but basically the PTAC, the President's Information Technology Advisory Committee, which led to the ARRA and high-tech and meaningful use and all those things. Basically, it said, if only healthcare would communicate about as well digitally as the finance industry does, we might save something like We thought originally it was $70 billion. Now the number from Institute of Medicine is more like $700 billion a year, huge numbers. We'd save huge amounts of money. Everybody'd be healthier and live longer. And we didn't have an entirely new kind of science. But other than that, it probably wouldn't be worth doing. But so this is now 13 years ago when HIPAA didn't seem to be accelerating health communication, and the PTAC was produced what ultimately led to the meaningful use and bribing people with $30-some-odd billion to make meaningful use of EMRs and whatnot. Here we are now, 5, 6, 7 years after that, depending on how you count. And if you read the blogs, if you read the world, everybody's complaining that it's not working, that we still aren't communicating, that doctors' lives are miserable, that everybody's a slave to the computer, that patients aren't in the loop, that other care team members aren't in the loop, that doctors don't send things to each other, certainly not out of the hospital or out of the same system. And this is why the three of us have gotten together on DataMotion's advisory board, the sponsor of this webinar today. DataMotion has a secure messaging platform that we think might be a basis to help move data and actually get people to send stuff to each other. And if somebody could figure out how to get the adoption up, which is part of what our goal is, so that we can get clinicians to actually send stuff to each other and understand that the HIPAA and privacy and security and identity and other issues are taken care of, and understand that the issues of integration into the EMR and the rest of that sort of circle, integration into workflow, are taken care of. Then maybe we can get on with, actually sending a message to the other doctor, or sending a message to the nurse practitioner, or the patient even, or the patient's sister, or the daughter, or somebody to help nudge or move care forward. Because if we can get people actually communicating, then it feels like, this charge that came out of PTAC would turn out to be true, instead of yet another sort of argument on why it is that people don't use these technologies.
Yeah, Peter, Dennis Robbins, I'd like to jump in to follow a bit. I think one of the things we need to do, we talk about clinicians and we talk about patients, and for someone who's healthy, they might see their doctor less than 30 minutes a year. And there's a lot more in the year than 30 minutes in which most of us live our lives. And if we're really talking about getting people to become healthier and to bend the sickness curve, which ultimately we need to do if we're going to bend the cost curve, we need to think beyond the clinical forum, but we want to make information safe and secure, so any of us will be willing to share that information, particularly information about genomics, STDs, behavioral health, that could otherwise come back and haunt us. And we do have the ability now to do secure messaging and to do it in a way that's not overwhelming for the individual person. And there's all kinds of ways in which we can engage the person to be involved and to have confidence in the system. It's not just about clinicians and sick people. It's about all of us. It's to make a healthier and a better world. That means we need to start embracing unstructured data. It means we need to think about moving not to just fetch approaches, but push approaches. I know you'll want to respond to that, but I think this can require a rethinking that can be so much more robust and so much better for our nation and the people that live within it.
Dennis, this is Bill. I agree with you, but the things that we're talking about right now, they give people the assurance, give patients the assurance that they can securely communicate with their doctors, and vice versa. Doctors can securely communicate patient information with anybody they need to. But there's a cultural problem as well. This tool and other tools have been out there for a while, but I think the IOM report from 2012 called The Best Care at Lower Cost really pointed out the issues. They used examples in the negative to show what the cultural issues are. For example, they said if we applied the current culture of healthcare to banking. We would be standing in front of an ATM machine for days waiting for our money because the records had been unavailable or lost. Or we'd go to the grocery store and the product prices wouldn't be posted, and the price would vary depending on, even within the same store, depending on the source of payment you used or which cashier you went to. And the pilots would be free to design their own pre-flight safety checks or not have one at all in the airline industry. This kind of cultural application to technology is kind of nuts. And so we have to find a way to apply this technology within a culture that makes people feel safe, comfortable, and communicative about their health information.
Yeah, this is
certainly
Peter,
concur.
and I completely agree with that. And the question is, how do we get the whole community to make a move, or similarly, how do we get the CIOs of health systems to make it so their doctors aren't in complete revolt, to make it so that they actually get positive ROI out of these very, very expensive systems, to make it so that they actually engage patients, and especially as we move to the capitated model, how do we get it so that the costs actually go down? They don't just theoretically go down. One of the mistakes I think we've made in the academic / science / regulatory community has been that we've decided that the only kind of data that's worth creating or sharing is highly structured data, and that the only method that would make any sense at getting at that data is to put all data about every patient in one central place, make it available so that if a clinician or anybody needed access to it, or the scientist, they could just get the access with the proper rights and permissions. I would submit that we've never done that for anything else in the world. When we have central repositories of data that people get at, think of an airline reservation system, that's relatively few data fields, 100 or 200 airlines, a bunch of flight numbers for each one with times, and demographic information about the people flying, and some money to pay for it all. There's probably 50 fields worth of unique data in all of that. And they're all well understood, they're all well structured, they've been structured forever. And we understand that. In healthcare, most of the things that we want to talk about with each other are nuanced things. It's not just that the person's diabetic, hypertensive, and is on these meds. It's why this med is this one and not some other one. It's the nuance of the why, or the subtlety of what's wrong with this mix right now. What's wrong isn't that the diabetes is true, or that the hypertension is true, or that the numbers aren't quite right. It's usually something else that's not obvious. The pill color doesn't go with this person's psyche, or something, the taste is wrong, or there's all kinds of things that couldn't possibly be put on a pick list that wind up being the subtlety of why something works for a particular patient and doesn't work for another one. Those sorts of things convey well in unstructured communication, like a conversation or like a note between a clinician and another one. And those things are particularly difficult to keep track of in structured databases. So because we've focused so heavily on structure, and we're still hearing more and more and more of it, it feels like it's time to enable or re-enable unstructured data. If a patient doesn't know their vaccination record, or they don't have a complete sample of it, but they need to know, they go rummaging around in the kitchen cabinet and pull out some yellow card from 10 years ago, wouldn't that card, written in pencil and pen with 5 different inks over 20 years, still be more useful than no data at all? And to the clinician, the answer is absolutely yes. So wouldn't a photograph of that card sent to the clinician or the nurse or the whatever be more useful than nothing at all? And the answer is yes. I would submit that semi-structured data, dictations, transcripts, photographs, drawings, things like that, sent from one organization to another or one person to another, is still the most useful kind of information to the human, and by embracing it and allowing people to use more of it, yes, it's not as easy to integrate into a machine that's going to tabulate things or into science, but it's much more appropriate for humans to share. And I think we just need to get back to doing both.
Yeah, Peter, this is Bill again. I think it's a great transition idea, particularly for patients. For people, communicating in text is a very positive thing if they can be assured of the confidentiality of that information, that it's transmitted to a specific individual and can't be seen by anybody else. I think that's a very good way to get into it. It doesn't deal with the longer-term issue of trying to make the healthcare system in general in this country a learning system where we have the structured data necessary to figure out what the population issues are or where the Zika virus is popping up automatically. But it certainly gets to the point of making people feel comfortable about communicating their health information. And in fact, that may be the key to getting past this cultural situation that we're in right now. If the patients would push for this communication, even in this unstructured form, and we provide the low-cost mechanism for them to demand that this kind of communication go on, then there will be a push to make this thing work. But clearly, passing a law or getting an IOM report or getting Congress to pay doctors some money isn't enough. We have to educate the patients so that they demand this kind of communication capability.
Yeah, I was involved with a transcription company, 10 and 15 years ago, and was all excited about the fact that the data was already digital by, over the last 20 years, people have been using PCs instead of typewriters to translate the dictations into something. Therefore, the dictations were digital documents. I read a study, I can't remember exactly, it was probably 5 years ago, or maybe it was somewhere in there, in which the Veterans Administration took the data from transcriptions, from admission summaries, discharge summaries, procedure summaries, and things like that, and ran it through some natural language work and created alerts and warnings and things like that from it. And did the same work against the structured data in the EMR, and it turned out that the data derived from the unstructured but digital dictation and transcription data gave better results than data from the highly structured system. Similarly, I've seen studies that show that the dictations have fewer errors. It's very common for clinicians to cut and paste or copy or to not be able to find the pick list for the exact thing they're thinking about, and therefore just pick something that's close enough, or something, the last hypertensive diabetic person with Crohn's disease, and start from there, but they don't quite fix everything. And so it turns out that a lot of the clinical systems that are based on highly structured data, stored data, have more errors in them, more substantial errors, than ones that came from a clinician thinking through a problem and summarizing it for another clinician. So those data start out as data. They're not photos of paper. And they have more nuance in a denser form and more appropriate information and more subtlety for the next clinician. But we tend to not even embrace that kind of data. We tend to think, well, if we can get rid of dictation, we can save the money for that world and apply it to our EMRs and other structured, more highly structured arenas. So
yeah, I'd like to build that. Go ahead.
Go ahead. Yeah, I'm not suggesting we give up on the EMR or structured data, nor am I suggesting that we think that photographs of handwritten notes are the way to go. I'm just suggesting that by hating the the poorly structured and lousily structured data so much, we've given up on a transition mechanism that can help us get to where we need to be. And if people start sending whatever they've got to each other, that data will make it into more and more structured formats as it gets used, and we'll get to the right place anyway. We just need to solve the security and privacy and ubiquity problem of that communication.
Yeah, Dennis, the ubiquity problem is the ubiquitous sorry.
Let's have Dennis jump in real quick, and then we'll get to you, Bill.
Yeah. So the point, I guess, Peter, that's pretty in between or sandwiched in with what you're saying, is that it's the transmission of information, the availability of diverse kinds of information, getting people comfortable sharing information. But the other component you raised, I think, is really huge. We want to make information actionable. We want to make it useful. We want to make it timely. So by using other things like AI and natural language processing, as you mentioned, where we can have this more continuous, we can integrate more live analytics, we can do something to nudge or cajole people or to give reminders to sustain what we're trying to achieve, it becomes hugely important. And that we need to augment that as well to make this something that becomes a living process rather than something stuck in an EHR. Go.
Dr.
Yeah,
Braithwaite?
so this is Bill. I was going to add to that the ubiquity of the solution is clearly one of the problems. And we look at the ubiquity of cell phones in our population now. It's estimated that 90% of the U.S. population has cell phones, and at least 3/4 of those, and rapidly growing numbers of those, are smartphones. People carry the capability of doing email and Facebook and Twitter on them, with them at all times. So the ubiquity is there in terms of communication. What we need is the ubiquity of secure communications to another person so that you're not broadcasting it on Twitter when you're sending your information to your doctor. You need to have that conversation comfortable and confidential, but using the same technology.
Right. Yeah, and the basic rules of HIPAA, and I'm an oversimplifier, so correct me if I've gone too far, but the basic security rules of HIPAA boil down to know who the sender is and who the receiver is. That's the identity problem. Encrypt the traffic en route. Make sure the people agree on how to take care of the data, that they're going to do a good job of it. That's the BAA, or the contractual agreement. Those are the big, and log everything. Those are the big pieces of HIPAA. And one of the reasons we've got, one of the reasons we've all joined the DataMotion, or at least I joined the DataMotion board, is because all those components are natively part of the system, and so is integration to essentially all the EMRs, so that somebody can get something. If any of these documents show up in an EMR input sleigh, they'll wind up just flowing straight in. They might be in a place where you have to view it with a PDF viewer instead of a native, but they'll at least get into in there. And likewise in the other direction. But every clinician in everyday practice runs into these problems where the patient came from out of town, or they're a snowbird or something, and they want to get the data to that other clinician that's 5 states away. And there's no easy way to make that happen. Making things hard for people is a guaranteed way to make it never happen and to get people frustrated. So to the extent that something as simple as sending a message to someone that can be directly imported, it could be cut and pasted, it could be directly automatically imported, it could become part of a workflow, it could be any of those things. And we know for sure who the sender is, and we know for sure who the receiver is, and that the strength of the security and privacy is well maintained. That sort of a system is, the 4 or 5 years ago, Meaningful Use 2 came out with a sort of a requirement to enable the direct protocol. NHIN direct is the more big. The NHIN Connect is sort of the name of the static data, highly structured data sharing. NHIN Direct is the name of the sort of lighter weight data sharing. Most of the NHIN Direct protocols are based on email, which limits file size, but otherwise is pretty ubiquitous, as long as you get the identity working. But you know, there are ways to make it so that even file size limitations go away, and integration of the EMR goes away, and those kinds of things are coming and are here. So it seems like this is these piece parts are enough to get the flywheel moving of people, particularly clinicians and their care teams, actually sending stuff to each other and getting people comfortable with sending stuff to each other, like we have for the last 100 years. Clinicians have long sent U.S. mail or telephone calls to each other to introduce them to the other patient. Now we hit a button and an 80-page output from an EMR that everybody hates is available to the other one. And most people who receive an 80-page quote summary from an EMR find the little handwritten note that sort of really nailed everything, and they really enjoy that. So I'm sorry, I'm ranting a little bit in circles here.
Well, Peter, let me add to that too. I think one of the things we have to understand is the realities of the clinical forum and how we operate. And one of the things is we don't have in today's world time to read and prepare an 80-page document before someone is seen if they come into our office or in urgent care or wherever they may be. It's just a reality. It doesn't happen. So that information may be there, but it's not being used and it's not actionable. So something that gets us what we need when we need it is what we need. Did I say that well? I guess so.
Well said. That was beautiful.
So this is Bill, Peter. I had to butt in when you simplified or oversimplified the HIPAA security rule. I think you do have the essence right. If you know who's sending it, you know who's receiving it, and that it's encrypted in between, you have met the basic requirements for security risk analysis that HIPAA requires. But it's just a small part of HIPAA. In fact, the general part of HIPAA that really doesn't do much more than the standard security rules that we all operate under, figure out what the risk is and do something to prevent the risk from happening. And you've kind of nailed that. But you must admit that that's not far enough when it comes to exchanging health information, that you can solve that aspect of the security rule and still get people afraid because of the interpretation of the privacy rule to actually communicate.
Yeah, there's been the White House recently, I don't know if they published this narrowly or widely, but I've seen some output from the ONC about if, some upcoming ideas that if, there's currently it's been on the books for a while now that care settings, hospitals, doctors' offices, and whatnot, labs must be willing to share digital versions of the results of the record with patients. The new tweak to that is that if these organizations receive meaningful use money, they must be willing to share that using the very techniques that meaningful use required, like NHIN Direct. To the extent that becomes more and more available, and patients, I personally, and I think most of us have these stories. I personally helped one of my family members get some blood tests, and then went back to the place and asked for the results, and they wouldn't give it to me. Of course, I'm a doctor, and they wouldn't give it to me or my family member. And despite the fact that we got to their boss and their boss's boss, they still wouldn't do it. And so I asked the White House if they could make some kind of a card with the White House emblem on it and put it on a piece of paper and make it embossed or something that people could carry around and hand to folks and say, for gosh sakes, just give me what is owed me. So part of that is indeed an education thing. But to the extent that we start getting people, I do think the majority of this transformation will happen as the mobile computing set and the younger set tends to start demanding it. And
yeah, I agree. Demand is the key.
Stuff. Yeah.
Yeah, that whole.
Well, it's important enough for them to do something, right? To them.
Right.
Right.
It's all about the
person. Yeah, all of us take care of a parent or an aunt or a cousin or somebody who's, you know, had a stroke or is getting older or has got some problem, and all of us get really, really frustrated at being able to try and figure out how their, you know, what results they got. You know, I had a family member who had a pulmonary, a sleep study in, and they moved in with us, and we were in a different state, and the next doctor wanted to get another sleep study, and we said, well, let's just get the results from the first one. It's only 4 months old, right? And we went to that hospital's EMR, and they had lots of stuff there, but they didn't have the results from the sleep study, even though it had done 4 months earlier. And endless calls later, you know, the answer was, well, we don't usually post our sleep studies to the EMR. And it's like, well, why not?
Right.
Well, can you send me the results? Well, I can fax them to somebody. And then we went another 2 weeks in trying to get the fax to happen with real doctors communicating with other doctors, asking to please send the fax results of a sleep study. This is nuts. You know, if the patient or the son or daughter or whatever of the patient is driving the case and trying to make things happen and save money, time, travel, all the rest, they are in a natural position to help drive this. And using protocols like Direct and platforms like DataMotion, there should be no reason that patient couldn't say, just give me this stuff on my mother or give my mother her stuff on this account. And I'll forward it on to the next doctor. If you can't get it done, I'll get it done.
Peter, you're absolutely right.
Dennis, would you be willing to share some of what DataMotion has been able to do in traversing so many different EHRs? Because I think people would be very interested to hear that. Because in my experience, nobody else has been able to do that. And that's kind of interesting in the interoperability, interconnectivity space.
Well, yeah, the DataMotion platform is the native hook for this direct protocol in 61 EMRs. It's integrated with another couple of dozen EMRs. So essentially all the EMRs that are used in the normal world are natively, have a native connection protocol to this system. So there's no, you know, it's hours worth of work to get this stuff working, not days or weeks or months of integration. That's just because those protocols are required by meaningful use, and if the hospital or clinic office, you know, got the check, then they've at least got the basics already working. So little steps can make this actually work. The advantages the DataMotion platform did beyond that are having an identity platform that can bring on new people essentially on the fly. You don't need to wait for a notary and a bunch of round-trip things to get somebody to get an address in the system. It can happen within a minute or two with a totally automated system. They've reduced the cost of all that by more than tenfold, down from an average of $100 down to an average of 10 or so to get new clinicians and others on the system. And they've got an unlimited file size, so there's no need to. You could send things like X-rays and other things. So yeah, it's getting there. It's getting close.
Very good. Let's hold on one moment. I just want to thank our sponsor real quick, and then we'll get back to our questions. You've got a slide here that sort of explains what DataMotion is up to, and I'm just going to read some quick information for you, and then we'll get back to our questions. DataMotion Health is a division of DataMotion, Inc., which has more than 16 years of experience providing secure data delivery services to healthcare, government, financial, and insurance industries. The entity empowers care teams to communicate more efficiently across the care continuum and with the persons they serve. It provides messaging and connectivity solutions for the secure and compliant exchange of PHI for clinical use and as part of the business of delivering improved person-centric care at reduced costs. For more information, check out datamotionhealth.com. Let me get one question from the audience in front of you, gentlemen. Dr. Braithwaite, we could start with you on this question. This comes from certainly a well-known attendee of our webinars, who's a former CIO. As we talk about cheaper, faster, and better for healthcare, what is your perception of the amount of waste that exists in healthcare? It appears that as much as 1/3 of healthcare procedures are unnecessary. How do we get to addressing the waste?
Well, I think the very topic that we've been talking about, which is interoperability, and the very issues that we've been pointing out about communicating the results of studies between one healthcare organization or one physician and another are at the root of that. Very few healthcare institutions that, at least from the doctor's perspective, will reorder a test when another test has been done somewhere else from a reputable source and is available immediately. And we can't get them. Peter's just talked about the fact that it's very difficult to get those things through the system right now, even though we have implemented the technology for doing that. It just reminds me of the fact that if I want to deposit a check today, I can use my smartphone, which communicates electronically, instantaneously, and securely with my bank. I just take a picture of the check and it's done. I can't do that today with a yellow vaccination card or with an x-ray or anything like that with most environments. If I could, and I could get that data instantly and quickly, then I wouldn't be ordering additional tests or additional redundant tests.
Very good. Let me just
by the way, one way to solve that problem is that if we believe that the system that's required for all meaningful use compliant sites, this direct, is working, and it is. It's not pervasive yet, but it's working. And that little tweaks like we've just been talking about are enough to get it over the sort of utilization hurdle, lowering the cost and making it unlimited file size and all that ubiquity-related thing. Then it could be that the people who do the paying could say, if the test was done and you didn't send it through a common protocol, then I'm going to dock the person who should have sent it, right? Or something like that. There may be some financial incentives that should stop test duplication. But that 1/3 number in the questioner's name was known to the PTAC 15 years ago.
And it hasn't changed very much.
No, it hasn't.
Yeah. There's another component of which we haven't spoken here, too, and that's the misperception sometimes of legal liability. And if we can get people to understand what the spirit of this thing is and what it can do and what we can achieve by doing it right, we may be able to diminish some of that, those hyperbolical sort of approaches to what risk is, and to understand risk in a really intelligent and meaningful way.
Let me just get one question out there, and then you can each take a shot at it, and we'll be about out of time. It seems like we've touched on, so we're talking about information communication among clinicians. We've touched on some issues that prevent that, which may or may not be, largely solved. So we've got security issues, right? We've got technical issues. We say there are tools out there like those from DataMotion that make this possible and secure. Shouldn't be an issue, but you still have people that have concerns. You've got a legal framework, which Dr. Braithwaite touched on, that should make people feel comfortable. So legally, technically, we should be where we want to be. But again, Dr. Braithwaite, you touched on the cultural issues. And these could include issues of being afraid of someone stealing your patient, or reimbursement issues, or who's paying me for my time if I go and I'm sharing this information and it takes time. So what I want is an overview from each one of you of what is the biggest inhibitor currently to information being shared the way you all want it to be. You're all passionate about this issue. What's the biggest inhibitor and what can be done? Dennis, why don't you start?
It's always good to ask a non-IT guy a question like this. Thank you very much.
Anytime.
So I think it's a number of things. There's not one solution. I think, again, the last thing I said, there's often an exaggerated sense of what legal liability is, and we often take the approach that we get from more of a paid paranoid sort of approach rather than what can we do and do it well and how can we stay within the constraints and the limits of what's there. So a better understanding of that area is one. I think moving to utilizing, as Peter had indicated earlier, the importance of more unstructured data and have people have things at their fingertips where it's seen as being helpful and not onerous, and to better integrate the person into the process. All of these things, I think, would be extremely meaningful in terms of making a difference.
Dr. Braithwaite?
Yes, I think that education is at the root of the solutions to these issues. I mean, we have talked about the cultural issues, but those can be overridden if there's a demand from the patients for this communication. And through the patients and the people that they hire, people that they pay to pay for their health care into the culture of the healthcare system, that can change. The other aspect of the education is to educate the system and all the CIOs as part of that, that the cost, the overall cost of ownership of doing it the right way is very low now, and it's low enough that everybody should be doing it. That message doesn't seem to get across the industry for some reason. But if we can educate the patients to demand it and educate the CIOs that they can do it, and it's cost effective to do that in the current environment, I think we might get a change past the cultural barriers.
Very good. Dr. Tippett?
Yeah, I think that, and thank you so much, I think that the legal issues, the safety and security and privacy issues are essentially solved. I've got lots of things that I can imagine would make HIPAA better or cheaper or stronger, and the same for other legal and regulatory frameworks. There's all kinds of things that could make it better, but I would argue that it's more than good enough today as it stands. So we don't need to reinvent or improve HIPAA or its deployment in order to make this stuff work. Likewise, we have the protocols deployed in EMRs and EHRs and in all the various systems. We have deployed all of the connectivity. We've got plenty of computing power both in PCs and in mobile devices and whatnot, so that these sort of data sharing systems can work. And there's plenty of integration capabilities with EMR to make good enough work. What we need to do is not let good enough get in the way, perfection and beautiful, perfect structured everything get in the way of good enough. Let me just give one quick example. There's you mentioned the not getting charged, and that might be a thing. One of the data motion implementations is the very large hospital system discovered that since the data motion platform has the patient ID number as part of its profile for each patient that the clinicians communicate with, that every time a clinician communicates with a patient using that system, the log of that can go back to the Epic billing system, which can wind up charging and getting revenue that was never capturable before. So all of a sudden there is new revenue possible, although less per encounter than a visit, still new revenue. And all of a sudden there was a new value to actually talking with patients over such a system. So I think the overall problem is what a lot of the tech startup people call crossing the chasm, that once we get a big enough group of people communicating this way with both structured and unstructured data with some integration and using the standards, this flywheel will get flowing and people will realize the benefits on each other, just like the benefits of email and word processing and mobile devices and everything else wound up getting across the chasm, and then adoption happened.
Very good. Well, that is about all we had time for today. I want to thank our panel, Dr. Peter Tippett, Dr. Bill Braithwaite, and Dennis Robbins for an excellent conversation, bringing to light an important issue I know they're all passionate about, trying to get things moving in this area, information being shared for the benefit of patients. I want to thank our sponsor, DataMotion, as well. As I mentioned, you'll receive an email when our archive recording has been posted to our YouTube channel within 2 business days, if not sooner. For those of you who have the CHIME CHCIO certification, let CHIME know you attended. Attending our webinars gets you one CEU. If you've asked us to let CHIME know, we will. Sponsorship opportunities, you can contact Nancy Wilcox. General questions and comments, you can reach out to me. You will, when you close out your WebEx window today, a survey will pop up asking you what you thought of our event today. Please it'll take less than a minute to answer it. And you go to our website to view our upcoming schedule of events. So once again, I want to thank our panel, our attendees, and everybody have a wonderful day. Thank you.
Thanks, everybody.
Thank you.